Thank you for joining this OncLive peer exchange entitled Global Perspectives on Prostate Cancer Management. The treatment of prostate cancer has changed significantly in the last decade owing to the introduction of several novel therapeutic strategies. Yet challenges remain in selecting the optimal course of treatment for an individual patient with non-metastatic castration-resistant prostate cancer, M0-CRPC, or metastatic disease. There is a growing appreciation for the biologic heterogeneity of advanced prostate cancer and the need for more personalised approaches. In this OncLive peer exchange, I'm joined by an international panel of experts in the field of prostate cancer research. Together, we will discuss the latest evidence surrounding the treatment of non-metastatic castration-resistant prostate cancer, M0-CRPC, metastatic disease, and also hormone-sensitive prostate cancer. We'll focus on the current approaches for bone-targeted therapy as well as future trends for treatment with PARP inhibitors. I am Joe O'Sullivan, Professor of Radiation Oncology at Queen's University Belfast and Clinical Oncologist at the Northern Ireland Cancer Centre Belfast in Northern Ireland. Participating on our distinguished panel are Nick James, Professor of Clinical Oncology at the University of Birmingham, Queen Elizabeth Hospital, Birmingham, United Kingdom, and Noel Clarke, Professor of Urological Oncology at the Christie Hospital, Manchester, United Kingdom. Thank you for joining us. Let's begin. So initially, we're going to talk about hormone-sensitive prostate cancer. Nick, you're a well-regarded expert in this field, and I'd really be interested to hear your perspectives on some new data being presented this week here at ESMO.
Yes, thank you. So we have two bits of data from the STAMPEDE trial. The first of those is the part of the trial where we've examined the role of radical radiotherapy for men commencing long-term hormone therapy for newly diagnosed metastatic disease. So we already know at the left-hand end of the spectrum that adding radiotherapy to hormone therapy reduces the prostate cancer death rate by about 50%. It's a big effect. So we hypothesise that that effect may well not stop sharply at the M0, M1 boundary and may carry on into the M1 population. So we've randomised altogether 2,200 men between systemic therapy alone. So in the main, this was ADT only. In the later patients, it was ADT plus docetaxel. The randomisation was stratified, so we have equal numbers of docetaxel patients both sides of the randomisation. The other thing we did for the first time here is we split the patients up by high volume and low volume disease, because we hypothesised that you might see different effects if you were treating the majority of the disease, as in low volume disease, up to 4 metastases, versus high volume disease, 5 or more metastases or visceral metastases. And what we saw, and Chris Parker presented these data on behalf of the STAMPEDE group in the plenary, was that for the whole trial, there was an effect from prostate radiotherapy on failure-free survival across the whole group. However, but there was no effect on overall survival for the whole trial. When we partitioned it into high and low volume, what we saw was that for the high volume disease, actually, as we partly predicted, there wasn't much of an effect, there wasn't any effect on survival. Whereas for the low volume patients, there was a substantial survival effect. The hazard ratio was 0.68, which is actually bigger than the hazard ratio for benefit than we saw with chemotherapy previously. So this is a highly significant effect with a big reduction with a very simple, very easily available treatment. Yeah. So our conclusion from this, and we published it simultaneously in The Lancet, and there was an editorial alongside it in The Lancet, was that this changed the standard of care for men with, if you like, oligometastatic disease at diagnosis. So that was the first thing we presented. Yeah. The second thing we presented looked at the question of where does the benefit from abiraterone sit in the same population. So last year at ASCO, we presented a broad spectrum of patients, M0 and M1, alongside the Latitude trial presented by Karim Fizazi, which was purely what they termed high-risk disease, so a slightly different risk classifier to the charted one, but broadly quite similar. And so that changed the license for high-risk prostate cancer, but not for low-risk prostate cancer. So what we've done, and in fact it's Noel's research fellow who's done the classifiers for us, is we reclassified all of the abiraterone scans and the matching controls into high and low risk for that part of the analysis, and showed very clearly that the benefits, not very surprisingly I have to say, the benefits for abiraterone aren't restricted to the high-risk patients, they're just the same in the low-risk patients. Yeah. So we feel this gives you very good justification for changing the standard of care across the whole spectrum. Obviously, there are license issues about that and reimbursement issues, but if you took those out, the clinical justifications across the
So
board.
the benefit for the patient was right throughout the spectrum.
Yeah, there's nothing to suggest that it was restricted to one or other subset. As in fact we saw with the radiotherapy, there was definitely only benefit in a predefined subset in that group.
Yeah, it's pretty amazing that local radiotherapy to the prostate gland can have such an effect. I mean, it's very exciting, really.
Yeah, I mean, there's a number of ways as to why that might be. I think the simplest explanation is it's just a numerical thing. If you've only got 1 or 2 Mets, you've treated 95% of the disease. If you've got 100 Mets, you've only treated 5% of the disease. So there's a simple numerical explanation. I guess that, we'd kind of like to believe there might be an immune explanation as well. You somehow cracking open lots of prostate cancer cells when you're starting hormone therapy may actually give you some sort of immune-mediated abscopal effect as well. And we're not able to test that in the data set we've had, but the effects are very real. The p-values are highly significant, so I think there's not much doubt, and it's biologically plausible.